All right. Looks like we have some people coming in. Today is Wednesday, May 7th. If you can hear me, say hello in the chat and where are you tuning in from? We've got some familiar names here. Hello, Jill. Hello, Eric. We've got a special guest here today that I'll introduce shortly. If you can hear me, please let us know where you are tuning in from in the country. Lori Dahl raised her hand. Great to have you here, Lori. Hopefully the chat is working today. Thank you, guys. Okay, I guess the hand raise is we're here and we are rocking. We have a Q&A, guys, as well. So if you have questions, feel free to type them in the chat as we go along. And thank you for participating and being here. We're going to kick this off. Today, I'm very excited to introduce Dr. Thomas Kim. Dr. Kim is a trailblazer in the value-based care, dedicating his career to expanding access through telehealth. As Chief Behavioral Health Officer at Prism Health in North Texas, he built an integrated behavioral health service that earned patient-centered medical home status with a behavioral health distinction. His clinical reach spans society's most vulnerable, from incarcerated youth and adults to military members, HIV/AIDS patients, disaster survivors, and individuals battling addiction. Beyond the clinic, he advises service organizations, academic centers, government agencies, professional societies, and health tech startups on strategy and innovation. He holds a BA in philosophy from Georgetown, an MD and MPH from Tulane, and completed Tulane's combined internal medicine and psychiatry residency, plus a general medicine fellowship. And he now serves as Chief Medical Officer of Noma Therapy. And today we are discussing the Noma Therapy program. So very excited to have you here today, Dr. Kim. Chat looks like it's disabled, but the Q&A is working. So if you have questions or chat, just pop it in the Q&A. And with that said, I'm going to hand the floor over to you.
Thank you so much, Scott. And thank you so much for all taking a bit of time out of your day. I'm just going to share my deck here and we can get rolling. Scott, can you confirm that everything looks right?
Yes, everything looks right, and I can hear you.
Outstanding. So, hello again. My name is Thomas Kim, and I'm delighted to tell you about Noma's virtual ketamine assisted psychotherapy offering. To begin, as mentioned, I'm an internist and a psychiatrist by training and Noma's co-founder and chief medical officer. For the last 2 decades, I've devoted my career to telehealth, creating new models of care by leveraging technology in ways that improve access, reduce costs, and delivers evidence-based quality care. When I started, I remember a wide open landscape with promising evidence, but no real rules or guidance and certainly no textbooks to look up answers. Along the way, I've been extremely fortunate to have contributed to maturing the field so that telehealth is now a vital tool in the ongoing care of patients everywhere. I was then approached to join Noma Therapy and was asked how would I do ketamine assisted psychotherapy, or CAP, in support of those with difficult to treat depression, anxiety, and trauma. What I found was a burgeoning field with promising evidence, but no real rules, guidance, or textbooks to look up answers. And fortunately, I've been here before. So I started combing through the literature to understand what ketamine is and is not. Ketamine, as you likely know, is a dissociative anesthetic used safely and successfully for many years in surgery. But rather than say things like NMDA or glutamate, I think there are really 3 key things to know about ketamine. The first is that it has a timely psychological benefit whose onset is measured in hours to days, with any given dosing response lasting somewhere between 3 and 6 weeks. This antidepressant, anti-suicidal response is actually quite remarkable, especially when you compare it to the expected response from conventional meds, which are very, very helpful, but whose onset is measured in weeks to months, if not longer. The second thing to know is that beyond timeliness, ketamine is also time limited. I often tell patients that there really is no solution in the bottom of a pill bottle. This is not to say that medicines are not helpful, they absolutely are. But it's important to recognize that the solutions that patients truly seek are actually inside of them, to be revealed through the skill development and mastery found with psychotherapy. And lastly, something not really talked about as much is that given what we know, how are we supposed to use ketamine to optimize the psychological well-being of patients? Historically, we used ketamine in high doses episodically during surgery and kind of accidentally discovered the psychological benefit along the way. At the time Noma launched, I constructed a model that questioned whether the dissociation phenomenon at high doses was required. And thankfully, in July 2024, a study team actually looked into that question and compared microdosing, taking a little bit every day, standard, otherwise known as non-dissociative or psycholytic dosing, and high psychedelic dosing. And while more research is definitely needed, what they found was that microdosing does not appear to move the needle. Standard and high dosing, however, have a demonstrable benefit. When you compare the two, high dosing does not appear to give additional benefit when compared to standard dosing. So this very nuanced understanding represents the foundation of Noma's approach to CAP. We do not believe that ketamine is a forever medicine, nor do we seek to give it in large quantities, particularly given the absence of long-term safety data. The nuance here is that there are others out there who adopt a psychedelic dosing approach. And I can't exactly say they're doing anything wrong, given that they too can report timely, positive benefits. So let me turn now to sort of broadly describe how Noma's virtual CAP model works. It starts with a collaborative care team of 3. Our prescribers see patients monthly to assess ketamine response and adjust the dosing round towards a personalized CAP plan. Our prescribers also offer, if requested or interested, what we call conventional medication optimization to hopefully find the least amount of medicine for the most amount of benefit. Interestingly, we hypothesize that leveraging the catalyst that is ketamine may actually assist in deprescribing medication burden over the long term. Our guides represent the face of our 3-person care team and assist the patient in navigating everything from program encounters to aligning expectations. They also directly monitor patients during every dosing session. And our therapists round out our care team and conduct biweekly therapy, though weekly is also permissible and fairly common depending on patient need. The nuance here is around with therapy is timing. We aim to conduct therapy 1 to 3 days post-dosing to take advantage of what's broadly described as neuroplasticity, though up to a week also appears to be just as effective. And so, with our team, our core program is 4 months in duration. We dose biweekly for a total of 8 doses administered sublingually across a program run. We only ever ship 2 doses at a time for multiple reasons, and they include things like safety and the ability to adjust the ketamine dose towards a more precise, personalized CAP experience for every patient. Upon completing the 4-month program, it does not mean we just say goodbye. But the 4-month mark represents an intentional decision point to ask whether CAP should be continued or not. This speaks to Noma's core value around delivering safe and effective care. So, upon completing our core program, the options moving forward include graduating following a robust program response. Graduation, again, is not a goodbye, but rather good luck and reach back out if you ever find yourself slipping back into the hole. In time, we hope to better understand what long-term support with CAP looks like, where I suspect a periodic return may be helpful, but I also believe that a continual use of ketamine is not likely to be helpful long-term. A second option for patients would be continuing another 4-month extension cycle, given the continued need to work on active care goals. In extension or XCAP, all program features are identical to our core CAP program. A third option is when the patient is improved, but perhaps not quite ready to drive their own bus yet independently. And this results in what we call maintenance CAP or MCAP. The key difference here is dropping to monthly ketamine dosing and continuing therapy for that skill building and mastery for the next 4 months. So, after we opened our doors, we were immediately gratified that our program seemed to be very helpful to patients who had been struggling for far too long. And soon after that, we began to see patients who reported already being engaged in therapy or med management. It was never our intention to step inside an active therapeutic relationship. Those are very difficult to build and they should be protected. So we quickly adapted to offer an alternative, which we call collaborative CAP or CCAP. In the simplest terms, we at Noma seek to be a trusted CAP partner with community-based providers, offering what we believe to be the best-in-breed virtual CAP model that maintains high quality and safety while delivering meaningful support for patients struggling with difficult-to-treat depression, anxiety, and trauma. We seek not to just straight up recruit new patients, but instead we seek to collaboratively support the mental distress, which we all know has far-reaching negative impacts to both our mind and our body. But collaboration is a tricky thing. Given my experience training in two disciplines, I know that true collaboration is challenging largely because such work is not often compensated. But it is often superior to everyone just simply staying in their own lane. Because of this, Noma seeks to create the lowest lift possible while still collaborating in a meaningful way. Noma's efforts at collaboration comes in multiple forms with the singular theme of transparent communication. We set up a HIPAA-compliant text-based chat connecting a CCAP provider to the Noma care team. We also offer routine office hours, inviting folks to learn more about CAP, explore clinical cases or the state of research around CAP, and ultimately foster a collaborative community. The next area within Noma's CAP program that I'd like to explore is our patients. As mentioned, our target population is difficult to treat depression, anxiety, and trauma. This population is sometimes referred to as treatment resistant, but I'm not really fond of that designation, as it seems to suggest that the patient is somehow resisting the treatment. And while treatment resistant is often defined as some number of failed med trials, this is another descriptor that seems unhelpful, as if the patient has failed something. So, beyond just simply offering a more helpful word choice, difficult to treat highlights more than just medication response, given what we know about the impacts of adverse childhood experiences and negative social or non-medical determinants of health. Candidly, our target population can perhaps best be categorized by the traumas or wounds in their life that have gone unprocessed. Rather than adding to a list of unhelpful diagnoses, I tend to tell patients that while I'm an excellent diagnostician, I care more about their functional challenges rather than simply slapping another diagnosis label on them. This approach has led to the re-examination of certain diagnoses like bipolar and ADHD, which can oftentimes reveal themselves to be trauma, masquerading as something else. All of this is to say that while certain diagnoses may suggest limited benefit from our program, such as schizophrenia, some personality disorders, and active substance use misuse, we are always willing to assess patients and at least consider trying. And so the evaluation process that we have can be understood across three dimensions. The first is eligibility, which seeks to determine whether we can hope to deliver our program safely. Medically frail individuals or people who have conditions that impact safety would not be a good fit for our program. People with unique brain architecture like seizure disorders may also be unsuitable right now. Another consideration around eligibility is medication interactions, as stimulants, opiates, and benzodiazepines specifically are known to diminish the hoped-for benefit of ketamine. This isn't so much a hard no, but rather a complication that needs to be explored during the prescriber evaluation. The second dimension to consider is appropriateness. This is perhaps slightly unkind, but we at Noma do not seek to care for the ketamine curious. There must be a clinical target to address prior to enrollment. Fortunately, a patient actively engaged in care who is referred to Noma for CCAP has an almost 100% certainty that there is something to clinically support. The third dimension, and in my opinion, arguably the most important, is engagement. Our program is not easy and requires the patient to be present and show up over many months. Moreover, having a reliable and safe place to meet with providers and undergo dosing sessions is critical. This includes access to suitable technology, whether it's their device or their broadband internet, and some level of competence in using such technologies. But one thing I say over and over again is that we do not do anything to or for patients. But if you are interested and engaged in seeking a better version of yourself, our program may be the help you're looking for. Next, I'd like to talk about Noma's CAP and CCAP programs' affordability. Noma accepts most major insurance payers, including Medicare and Medicaid, though this varies by state. We currently support patients in Colorado and Texas, with active plans to grow into Arizona, New Mexico, and Florida. The insurance covers all clinical encounters, which may include copays depending on the insurance carrier. But because sublingual ketamine is not specifically reimbursed through insurance yet, we charge by the dosing session, and depending on your insurance, Noma charges $90 per dosing session for commercial and $62.50 for Medicaid. This translates to $720 for commercial insurance and $500 for Medicaid for the entire 8-dose 4-month program. For context, a single ketamine infusion can cost many hundreds, if not thousands of dollars. Other formulations like intranasal and intramuscular can be less expensive, but are still hundreds of dollars for a single dose. A final note on costs broadly is that Noma also does not charge collaborating community providers any fees for the privilege of collaboration. I'd like to end the webinar with my personal experience working with our tremendously talented and dedicated team. So, after 20 years of practice, I've grown quite used to the challenges of supporting mentally distressed patients whose struggles are often outside both of our control. The work is still satisfying, but challenging nonetheless, and has been shown to contribute to the high rates of burnout we see today. One of my patients at Noma was a Columbine survivor. For the last 25 years, he struggled tremendously despite meds and therapy along the way. After successfully completing our program, he shared a remarkable moment with his parents. They had gone out to dinner, and after dinner, they parted ways. His dad is described as sort of a stoic man of few words type, and in the car, he turned to mom and said with visible emotion, "After 25 years, I think I finally got my son back." Mom got emotional. Mom tells the patient the next day, who also gets emotional. Patient tells me soon after, I got a little bit emotional and still do when I tell this story. While I cannot guarantee similar results with all patients, this clinical experience renewed my faith in my profession and my confidence that we have built a special program at Noma that delivers meaningful results, and we aim to support as many people as we are able. And this includes our collaborating CCAP providers who share in and amplify the satisfying benefits of our ketamine assisted psychotherapy program. So I want to thank you for your time and attention. I hope that this overview webinar has been of interest to you and that maybe it's inspired a question or two, some of which I will seek to answer right now. But if you want to learn more about Noma Therapy's CAP program or are interested in making a referral through our CCAP program, you can check out our website at nomatherapy.com or send us an email at hello@nomatherapy.com. Thank you so much, and I look forward to your questions.
Amazing, Dr. Kim. Thank you so much for sharing. That's it. That's an incredible story. I love hearing the stories of the patient success because that makes, all the challenges of business very, very worth it.
I
Um,
agree.
yeah, so as the Q&A rolls in, so something off the top of my head, so being in the space for many years, we've spoken to companies that offer a similar deliverable. So in your experience, how would you say that Noma is different from other virtual ketamine providers?
Well, so when we set about constructing our model, um, I felt fortunate that I've been in the telehealth space for quite some time. I can tell you that there is a headwind of sorts when you start talking about virtual cap. A lot of people have very understandable concerns around how that would even work. And the way that I sort of unpack how we got to our model, which candidly, as far as I can tell, I I don't see many folks in this space that offer what we offer the way that we offer it. And it starts with the idea that when you approach it from a cyclitic non-dissociative dosing, this immediately reduces the potential risk. So when you mitigate the risk and you couple that to only shipping out 2 doses at a time versus, say, a 30-day supply, we have high confidence that we can avoid a lot of the concerns that have been expressed around diversion of a controlled substance. Um, in our direct experience, the other thing that I love about our virtual model is that in comparison to other options, ketamine centers and clinics, which do good work, I don't mean to cast any aspersions or shade their way, but I have had feedback from patients who have gone to an infusion center and described the experience as a little bit triggering, where they sit in a foreign space by themselves, typically in the dark. Yes, they have eye shades, and then they get shot to the moon and dissociated. And if you have a trauma history, that loss of control is can be distressing. It's not a foregone conclusion. What I've heard from our patients instead is that by dosing from the comfort and more importantly the security of your home, patients are able to have a very positive dosing experience. And one of the parts that I highlight, which I think is one of our sort of differentiating factors, is because we have a psycholytic approach, our goal is that for the dosing experience to simply be positive, borrowing from Leary and set and setting, and just have a positive experience. But where my interest lies is in the days and the weeks following the dosing experience, which we describe as the dosing response. That's where the neuroplasticity kicks in, where the opportunities for skill development arise.
Excellent. Great. Thank you. And I have Brian Richards has his hand raised. I'm going to click allow to talk. If not, you could just type your question if you don't want to talk, but oh, he put his hand down. Okay.
Okay.
Robert Smith asks, can you please cite the study from July 2024 about the daily microdosing?
I sure can. In my slide deck, um, I, I put in the URL, but obviously that was a difficult thing to do. I'm just looking up the lead author's name, which was uh, Shishadri, July 2024, in the Journal of Affective Disorders. And what they did was they were seeking what would be the optimal dose for ketamine. Now, again, this is one of the only studies with this specific question that I've encountered to date. And of course, more research needs to be done. I don't think anything about this study is definitive, but it certainly speaks to the work that we need to do into creating a more nuanced, a more established understanding of how we're supposed to be using this medicine in perhaps a different way than originally designed.
Yeah, and in all of my encounters with mental health professionals in the ketamine space, I've never heard a study about that microdose versus standard versus a macro dose. You didn't use the term macro dose, but that's how I'm.
Right. I do micro psycholytic psychedelic. And the other thing to keep in mind is there isn't like a hard line between these designations because everybody processes medicine differently. One of the things that I love about our program is over the course of 4 dosing rounds, our care team gets an opportunity to sort of dial in what that optimal dose is. And and this is our general response to patients who come, but so and so will send me 30-day supply of ketamine. And I think that that's just a different strategic, approach to figuring out how we're supposed to be using ketamine in service to the psychological well-being of our patients.
Absolutely. Okay, Brian Richards is back, so I'm going to click allow to talk. Oh, no.
Thank you. Scott, we've been in touch in the past. I work clinical psychologist with Gladstone Psychiatry and Wellness, so we're in the process of building out our ketamine services. Really glad to be on this call and just learn more about what you're doing. Question I have as a psychologist is how are you pre-post measuring outcomes? So just curious what you're using, how you've operationalized that, as I know that in the field, really across industry, the more we have definitive objective data, the closer we are to insurance reimbursement and really bringing it into the field in healthcare systems at scale.
I don't disagree, Brian, and I love the way that your head works because I have the same sort of inclinations. Our general approach now, keep in mind, we're not academically sort of grounded, but I tried to keep it simple. We have a pre and a post program packet of 5 assessments: PHQ for mood, GAD for anxiety, PCL for trauma, audit for alcohol, and the promise for the best we can do for social determinants of health that sort of broadly impact a person's general well-being. Every dosing round, we repeat the PHQ and the GADs. And on one of my slides, I may have gone by too quickly because I tend not to sort of focus in on statistics. But when we graduated our 100th patient, we did a look back. And what we found was that among our graduates, 85% showed meaningful reduction in their PHQ scores down to, sort of the mild single digit range, if not down close to zero, as well as a reduction in their GAD-7 scores. I believe it was 72% had a reduction in anxiety.
Wow.
What I'd love to continue to look at beyond simply self-report assessments would be, and I know this is anecdotal, so forgive the lack of rigor, but I can I can I can immediately recall a handful of the patients that I immediately care for, and I don't do this full time. I have other prescribers who do this all the time,
Uh-huh.
where I know that I've been able to avoid an ED visit, if not an outright hospitalization. And
Very good.
so, from a value-based standpoint, you're exactly thinking right, that I believe that ketamine, while not magic, its timeliness creates an opportunity, which is why I describe it as a catalyst to get us on a path that may actually have significant cost reductions. And so long as we have sort of an evidence-based quality and access sort of lens that we apply to it, I think there's something to this.
Very good. Yeah, the follow on, if I may, as we think about how to increase efficacy, Robin Carhart Harris, his lab just came out with an article on meditation and psychedelics generally. And as we think of like Spravato administration or ketamine with therapy, music, all these different things we can use to optimize the depth of the experience, I'm curious about the idea of meditative practice as part of what can be done with drug on board and with integration potentially as well.
So, wow. Yes, I agree with the promise of all of these interventions. And in our experience, our guides and our therapists employ lots of evidence-based approaches, as you rightly point out, which include meditative practice, but certainly journaling. And in terms of orientation, CBT is clearly at the top of the list. IFS, surprisingly, offers a really accessible framing that patients are allowed to, the way that I describe it is rewrite their story. Our program supports folks as they rewrite their story because nothing is fixed in stone. And perhaps I'm an unusual psychiatrist. I'm a huge advocate of therapy because I
Good.
really find that's where meaningful progress lies. And this dates back to the now probably very old data that I encountered back when I was in training, where it took folks stabilized on meds and stabilized on therapies and then stopped and watched what happens. And the folks that got better on therapy were able to sustain their wellness longer than folks on meds. And I found that to be a really profound statement. And so the other part of your question has to do with recognizing that ketamine is not a psychedelic. So a lot of people sort of lump them all in the same bucket because of the dissociative phenomenon. And while Noma has opted to take a psycholytic approach, I am keenly interested in how psilocybin and MDMA, despite the regulatory and the cultural headwinds that we face, I'm really keen to see what happens. I don't really see a pathway for clinicians like you and I to make their way in the way that Oregon is setting up. But one of the reasons that we founded Noma in Colorado is that they seem to be the second out of the gate to try and come up with a regulatory framework that allows clinicians to use this non-ordinary state of consciousness towards broader psychological well-being.
Yeah, very good. We've been using the term atypical psychedelic for ketamine and increasingly the term experiential medicine, which we feel is more accurate as a descriptor than psychedelic, meaning novel associations. And it's very different. Many people do not have a psychedelic experience, even when they're taking a psychedelic, depending on metabolism, et cetera.
Absolutely.
Great. Thank you.
Of course. Wonderful questions.
Thank you.
Thanks for jumping in live, Brian. Really appreciate it.
Sure. Glad to be here. Thank you.
All righty. Awesome. Okay, so on that note, what Brian was kind of just discussing, Eric asked, what about for other psychedelics besides ketamine? So I'm assuming that question is meaning, does Noma have any plans to expand into these other psychedelics or
So do we have plans?
yes.
Technically, no, because there isn't a pathway as of yet. Do we have interest? Absolutely. Because again, while I'm not seeking to disparage my 20 years of effort and conventional psychiatric care in general, I'm incredibly enthusiastically optimistic about this being effectively the first non-serotonergic approach towards supporting patients. And we've really built our program around the patient being front and center, driving this story revision.
Gotcha. Yeah, I know there was a bit of a setback with the phase 3 clinical trials around MDMA
I
earlier.
know there's sort of a split opinion around that. I think it's important to highlight that it wasn't no, it was not yet. This was a governmental decision that there was insufficient data in their estimation to proceed with the next step. That doesn't mean that this is dead in the water and never to be revisited. Um, I am kind of curious, given the current climate, because I see lots of positive and negative drivers that will either inhibit or help psychedelics broadly. We have a number of centers of excellence, including one here at UT in my home city of Austin, Texas, but they're scattered around the country. And I'm so grateful. I started my career as an academic up in Baltimore, um, and eventually made my way to Texas to do these very unusual things in telehealth and now with psychedelics. But I cannot be more grateful for the folks that are trying to answer the hard questions and to create a pathway in front of us so that we might be able to safely, reliably, and meaningfully help patients who are struggling.
Absolutely. I want to take a bit of a pivot and ask about the model around Noma Therapy. So, walking us through, you talked about therapists and prescribers. Can you walk us through how you collaborate with each of those and then what the model is?
Absolutely. So I believe that our three-legged stool care team is a big part of our success because it's not any one thing. I'm sure the therapists on this call and just in general have experienced the same frustrations in the past. I sort of liken it to beating my head against the wall trying to get somebody's meds optimized, but because of the duration, the time length, and other challenges outside of our control, it doesn't always happen. And when ketamine sort of catalyzes this rather robust, sometimes startling, positive, forward, now we have some opportunities to do stuff. Um, I was as surprised as any of us when patients started coming and saying, "But I already have a therapist that I love," and I was like, "Whoa, wait a minute! Like, I don't want to do anything to disrupt that." And so I reach out to every single therapist that we can identify, and I give a very similar, albeit slightly truncated, spiel on what Nome is about, and I invite them to consider caring for patients together. And the simple context of knowing when dosings are happening allows the therapist to schedule to bear witness to the moment of the dosing response and then to see whether their already good skills and capabilities have an outsized potential benefit, or at least this has been our experience internally. Now that we're working with therapists out in the community, there's a similar thing. I had a therapist reach out to me saying, I was taking care of this client for 2 years. These last 2 months, what happened? This is a different guy. And I love hearing stories like that. There are also situations that I think bear mentioning where prescribers out in the field reach out to me and they have a couple of different postures. One is if they're a primary care prescriber, for example, that they're carrying all of the heavy water with primary care psychiatry. Can you please help? And they're really delighted about the opportunity to work with us in the psychological well-being of their patients. If they are psychiatric prescribers, many of them express concerns about, I don't feel comfortable doing this. And I get that this is new. This is not without risks or considerations. And I sort of lay out our thing that I don't want to in any way disrupt you as their longitudinal prescriber, but perhaps this may down the road help with not only getting folks clinically better, but perhaps we can realize other things, as I mentioned earlier, the potential for de-prescribing medications, I think it cannot be, understated. there are fundamental flaws in our care system. The way that I sort of describe it to patients is our system is set up to wait until your level of distress is at the level of a house fire before we act. And the way that we act with distress at that high is we hospitalize you and we just pummel you with medicines and slap you with a whole bunch of diagnoses. I'm being a little bit uncharitable to my inpatient colleagues as a former hospitalist. I know how hard that work is. But if we could go upstream and use CAP, for example, to get folks on a more proactive path to address the distress that they are still feeling, but perhaps hasn't risen to the level of a house fire, we may be able to avoid a lot of the heartache and expense and distress and complications that folks do when they, before they do the hardest, bravest thing I know, which is to ask for help.
Thank you, Dr. Kim. So you have a pretty diverse background as far as projects and companies and things that you've been involved with. Can you take a moment and tell us a little bit more about the founding team behind Noma?
So one of the sources of my great esteem for Noma is that my boss, Andrea, uh, is a clinical psychologist with as many years of experience, and she has other tools in her tool bag as well. But because we're very clinician heavy on the masthead, it allows us to always ask, is this the right thing by our patients? It is why, right out of the gate, we accept Medicaid in the state of Colorado. It is why we continue to look for ways to improve the accessibility, and it's why we went virtual, as well as the overall cost, right? There's a lot of money to be made in the ketamine space. Not all of it directly benefits patients.
Absolutely. And I love this approach of, you're not just going to get a big box of ketamine shipped to your door. And it's really like so, you dose it out, how you ship it. And then in addition, kind of in layman's terms, how I'm understanding this is it's sort of like a bolt on. Like I have my iPhone and I love my iPhone. I don't want to change it, but I want to add a case. And that's going to enhance my iPhone, make it better, but I'm not disrupting the main thing, which is the iPhone. And so you're basically, this model is, that's the approach we're taking. We don't want to disrupt anything that's happening with the therapist or the prescribers. We just want to enhance it by being this add-on, essentially.
I love that analogy. Um, we also find that there are plenty of people without iPhones, and we will happily see if we can help them in them finding their best self as well.
Yes, and that's my non-medical marketing.
I get it.
So Tracy is asking, are there any medical conditions that would be counterintuitive to use ketamine? Like if someone has a chronic health condition or medications?
So when I first started talking to people about this, I had a long list, I think, of 14 diagnoses around things that were areas of concern. That has simplified a lot given our experience. So while there are risks associated with ketamine, the primary one of which is it's cardiovascularly taxing. When you take it, your blood pressure, your heart rate will go up. If you are vulnerable cardiovascular wise, we need to sort of sort that out. If you had a myocardial infarction, a heart attack last week, I'm probably not going to be super, super excited about either enrolling you or titrating your dose aggressively. If you same as if you had a stroke. There are far too many diagnoses for me to sit there and make a laundry list. What I've found is that as we engage with these collaborative relationships, folks will just send a message. I have this patient that has this area of concern. What do you think? And we sort of hash it out and saying, well, presuming we can do X, Y, and Z, and that might be further testing. It may be input from their medical provider. It may be, who knows? We will find a pathway towards enrollment if we can. I believe the last time we looked, our acceptance rate for all comers, both CAP and CCAP patients, is somewhere in the 80s. So we're turning away maybe 1 in 5.
Wow.
But we've also taken care of patients in their 70s, right? So frailty is it's a fluid term, right? There are no hard and fast lines.
Thank you. Gabriel is asking, besides infusion, what other route have you seen ketamine given?
Oh, multiple. So um, I think the most helpful way to think about it is at the top end of the spectrum, it would be the formulations that have the highest level of bioavailability. They also have a tendency to have the highest level of cost. And so it starts with IV, and then as you step down the line, you start getting into intramuscular, and uh, then for those of you who are familiar with the space, intranasal Spravato or S-ketamine is the only FDA approved version. It still holds sort of a requirement to dose within the clinical space. Again, I think that's largely these cautionary guidance regulations are largely based on the presumption that we're dissociating people when we administer this stuff. And I think that was based on the early clinical efficacy studies where we were giving six, the magic number was six, rapid succession, high dose infusions to see what the safety profile was. Would it kill you? And thankfully, it would not. It did not. Um, but if you're presuming that you're going to dissociate, yeah, you should probably, and it's cardiovascularly taxing, you should probably have a safety plan in place. Um, then there's sublingual, the formulation that Noma applies, where we have rapid dissolve tablets that go between your cheek and gum, and you hold it there for about 15 minutes. And then below that is, and with the lowest bioavailability, is an oral tablet that you swallow. Um, one comment that I have with that route of administration that is arguably the cheapest and has the lowest bioavailability is that it also has a high risk of nausea and vomiting that in our experiences sublingual does not. But then as you go up the scale with higher doses of ketamine, nausea and vomiting becomes a thing where a lot of folks pre-medicate with Zofran, which is an antiemetic and anti-nausea medicine. So there's a nuance to the art of medical prescription. I hope that wasn't too much, and I hope that answered your question.
Yeah, certainly. An art and a science. Absolutely. And anonymous attendee is asking about the different dosages. How do you know what to dose, etc.? And then a follow-up question is, what is the half-life of ketamine?
Gosh, I'm embarrassed to say that I don't have that at the top of my head. Um, but Mr. Google tells me that its elimination half-life is somewhere between 2 and 4 hours. And so that largely speaks to the dosing experience, what a person would undergo during the act of dosing. This in no way speaks to what I describe as the response, the 3 to 6 weeks of neuroplasticity. Um, does anybody have any interest in my take on neuroplasticity?
I would actually love to hear your take on it.
Okay. I love this term. I think it reinforces the notion that nothing is set in stone, right? While we can't reinvent the entirety of our brain, this organic computer is pretty remarkable. If we start with the context of depression, anxiety, and trauma for long-standing periods of time, what we know is a number of our basic neurotransmitters are low. In the case of trauma, you have a stress response, so your brain is swimming in cortisol. That's the state. When you do fMRI studies of normal subjects versus folks who are struggling with depression, anxiety, and trauma, there are a number of areas in the brain that go dark, that have diminished metabolism. Those include the prefrontal cortex and most of the limbic system. And the part that I like to highlight is the amygdala, which is the emotional seat of our cells. It's the part of the brain that we effectively need to feel. And this is why a lot of people who struggle with depression, anxiety, and trauma feel hollow inside. I don't feel anything. I just feel terrible. When you take ketamine, in those couple few weeks up to 6, depending on what study you look at, what we observe on those same fMRI sort of snapshots is meaningful signal transmission through parts like your amygdala. And so that kind of makes sense. I don't think it's the full answer because it's a complex organic computer. But the idea that we're recruiting parts of your brain that have been dormant, not because they're off, but because they've been overwhelmed with the noise of stress and trauma and depression, anxiety, allows us to actually have a more meaningful life. we're able to feel things more. And this is that timely antidepressant, anti-suicidal benefit that we're observing on the sort of the macro scale. Does that make sense?
Absolutely. Yeah.
Sometimes it's hard to speak in English.
Well, yeah, and then so part of like, what I spend my day doing is listening to very smart people like you, and then how do we translate this into someone who's, on Google or social media and get them to really like stop in their tracks and say, I should take a look at this. So from what you just told me, the way I understand it is it helps to light up areas of the brain that are dark. And it helps to get those areas functioning again. And then that can bring you back to a state of not being depressed or
Correct. But to be clear, not magic, not a silver bullet, not a permanent fix.
a tool.
When we have this catalyst response from ketamine, when you apply the skill development and mastery of psychotherapy, you simply become stronger. You learn how to do harder better, for lack of a better way to do it. And the more you practice things, that just becomes your sort of recalibrated state. At least this is how I like to think about it.
Love that. Okay. An interesting question here. Tracy asks, is ketamine fat or water soluble? I've never had that question.
Good God. Um, it has been um, many, many years since I was in a psychopharm class, but I think it's an important lesson for all of us to be able to say, I don't know with confidence, right? But the thing that I would encourage us all to say is, I don't know yet. So if you'll give me just a minute, I know exactly where to find the answer. And when you look at medical education today, there is a fundamental shift in the skill sets that we're trying to teach our future doctors, which is because the knowledge base is so much larger than 1, 2, 4 generations ago, it is important to be able to find the information and not to allow our egos to simply remain quiet. So, to that answer, and for those of you curious, I subscribe to Up to Date, which is a wonderful resource, sort of like a continually updating textbook. And where it is? Do you have any other questions loaded up as I'm looking for this?
My last question was going to be if people are interested in learning more about your program or you, how can they connect with you and Noma?
So I mentioned our website, and the card was too dense. And let me see here. It is water soluble. I hope that helps. Um, our website is nomatherapy.com. On it, if you are interested in referring a patient to collaboratively care for them, there is a tab that says for referring folks. Our referral form is not terribly exhaustive. It's a whole process that we try to make as easy and low lift as possible. And then the general email for anyone who's interested in learning more, or if you have somebody who's actively seeking the possibility of enrolling in a CAP program, there's also a pathway for patients to identify themselves. Uh, and so nomatherapy.com, hello at nomatherapy.com.
Amazing. I'm typing this in the chat. And then I was also provided a Calendly link that I posted in the chat twice. So if you guys are interested in setting up a call with Noma Therapy to learn more about implementing this in your practice, that link is there for you as well. And with that said, it looks like I've covered my list of questions and we've covered the list of questions from our attendees. This has been so great. Dr. Kim, thank you so much for being here and sharing your
It's truly been my pleasure.
Absolutely. So guys, this recording will be on our YouTube and on LinkedIn, and we hope to see you guys on the next webinar. And thank you again for being here, Dr. Kim.
My pleasure. Thank you, Scott. And thank you all for attending.
Have a good one. Bye-bye.